I am Meredith Hirsh, and this is Working Healthcare. But what's not working in healthcare? Patients wait while paperwork moves at the speed of fax. About 9 in 10 physicians say prior authorization delays care, and a similar share link it to burnout. Doctors spend nearly 6 hours in their electronic health record for every 8 hours of scheduled patient time. Americans paid close to $100 billion out of pocket for prescriptions last year. Those aren't abstract numbers. They're missed first doses, rescheduled infusions, and care teams drowning in forms instead of caring for people. Here's a picture. A rheumatology patient is prescribed a biologic. The script bounces to an out-of-network pharmacy. A prior auth auto-denies over a missing chart note, and the copay assistance form needs 3 signatures across 2 portals. Weeks pass, a navigation team pulls the note, files the appeal, enrolls the patient in assistance, and routes to the right pharmacy. The first shipment lands before the next flare, if you're lucky. That seam between a clinician's decision and the medicine in hand is where today's guest works. Today's guest is Mallika Khandelwal, founder of Squad Health, focused on prescription navigation for specialty practices. The messy mix of prior auths, appeals, financial assistance, and pharmacy routing that too often stalls therapy. Mallika began as an investment analyst in New York, later earned an MBA at Stanford, and despite growing up in a family full of physicians and being accepted to medical school, chose a different path. We'll ask why she stepped away from the white coat, how finance trained her to see healthcare as a system, and what it takes to fix the unglamorous back office where access lives or dies. Squad Health aims to shorten time to therapy, reduce abandonment, and lighten the administrative load on clinics. If it works, fewer patients wait, fewer clinicians burn out, and more prescriptions become actual treatments. Mallika Khandelwal, welcome to Working Healthcare.
It's so great to be here. Thanks for having me, Meredith.
I am so excited you're here. You actually approached me to talk about Squad Health, and I always like to learn the why behind somebody. And I said, tell me why. Why did you get involved in this? What's your background? And I said, I want you as a guest on Working Healthcare because you grew up in medicine just like I did. And at least in my household, I had a choice of being a doctor, a lawyer, or an accountant. And I became none of those things, but I do now work in healthcare. What did those dinner conversations teach you about care, responsibility, and why you either wanted to go into medicine or why you ran away from it at first?
It's such a great question, and I'm so excited to talk about why I am so passionate about such a complex field like healthcare. Like you said, I grew up with my whole dinner conversation focused around healthcare. My dad's a cardiologist. My mom is a maternal fetal medicine specialist. My entire extended family is full of doctors, and a lot of the discussion was around the misaligned incentives of healthcare. And it wasn't just my parents complaining about their jobs, which many people do. It was, truly difficult issues like why aren't patients getting the care they need? Why is no one listening to the doctor? Whether that's the administrator above them or the payer that pays them. It was really terrible. And also inspiring. Like there was so much to be fixed. And I was the closest of my 3 siblings. We all went to Harvard for college. I was the closest to ending up becoming a doctor. Like you said, I applied and got into medical school. And ultimately, I decided not to go for a number of reasons. And I think the main one was just this resounding feeling of unfairness to the doctor themselves. I wrote my entire business school essay on this, actually. One story like really, really captures it and makes me kind of feel the worst about this, which is that my mom, who I mentioned is a maternal fetal medicine specialist, delivers babies in high-risk pregnancies all the time. And there was one case where she happened to be delivering a really high-risk pregnancy, and things went awry. And, she was the last one to step in, kind of like the last person to try and resolve the issue. And there was, there was an issue during the delivery, but frankly, based on what could have happened, probably a good outcome. And instead, there were politics and complexities that led her to getting a huge slap on the wrist. That's just one example, right? But there are just so many, and we're going to talk, I know, about how this shows up for doctors everywhere. It was just one more example to me of why being a doctor today has just become so incredibly painful and difficult, despite the fact that so many doctors out there are just trying to help patients and do the right thing.
And that's why they go into medicine, because you don't have somebody who is so egocentric or somebody who doesn't care about other people going down the path to medical school. These are really caring individuals. I walk down my halls all day long, and my doctors and my nurses, it's just in their blood. They are the most giving and caring individuals. And you actually got into medical school and you shared a story with me. I would love for you to share with our listeners about why you spoke to a friend, a family friend, why you chose not to go to medical school pretty much at the tail end. And then you went to New York and worked in the business world.
Yeah. So after I got into medical school, I deferred for a few years because I was still thinking about whether it was the right decision for me. And ultimately, I ended up speaking to actually the dean of the med school. And I told him that my dream was not only to go to med school, but to actually become a leader in the fields. I wanted to become the CEO of a hospital to make change in healthcare. And he looked at me and he said, don't go to med school. Like, you don't need to go to med school to work and improve the business of healthcare. In fact, it will probably only slow you down. And to me, that was just that was the best signal I could have gotten from someone who knew what they were talking about, that there are other ways to improve the system than just to become a part of it.
And so continuing to walk through your path, and this is so intriguing to me because I have 3 sons and none of them are going into medical school. My oldest, for actually a big chunk of his life, always thought he would be a doctor, like his grandfather, like his father. And I think within 1 week of being on the high school robotics team, he was like, engineering. And he doesn't even work in that field anymore either. He did get a degree in mechanical engineering, but no. And then my middle one, there's no way he wanted to do those sciences. There was no desire ever for medical school. My youngest, for a really long time, thought he wanted to go to medical school. And he was a math major and a neuroscience major. And this year, as a sophomore, he dropped neuroscience. And your mentor, the dean of the medical school, said something very similar to what I said to Benjamin. If you want to create change within healthcare, being a doctor may not be that path. Now, I feel a little guilty saying that because I don't know if we're going to have enough doctors around to care for me when I need them. But I'll go back to what Kevin Daly said, who was a guest on the podcast, and he is a lobbyist. He said, when I call you to speak to somebody in Congress or a legislator, I need you to cancel your patients for the day or for 2 days, because you could make more impact during that conversation testifying to Congress or to your legislature than you can necessarily seeing those 30 patients that day. So it's really important to get involved. But you worked in New York in the financial world for several years. When did you decide to go back into healthcare?
I think I just had always dreamed of being a business leader in healthcare, that even when I was in the finance world, I was always charting my path to doing it. And after many years of investing, which I loved, by the way, it's such a fun industry to be in, I just didn't see how that career specifically would lead me to making that change. And yeah, I was at the moment where either I was going to take the next step, leave a firm and take a much more senior position, or I was going to make the leap and go back to healthcare. And I decided to just do it at that moment. I went and worked at a venture-backed health insurance company as a way to just start learning about the business of healthcare. And I'd simultaneously applied to business school at Stanford because I knew that if I were going to make the change that I wanted to make, I had to go early. I had to build a company or be part of building a company that did something differently. I couldn't just go work for a company that perpetuated what healthcare is right now. And Silicon Valley is definitely the place to do that.
And when you worked for that VC-backed company, doing investment banking, what did you learn was broken within the system? You obviously sat around the dinner table and you heard about it from your parents, your dad, the cardiologist, your mother, essentially high-risk OBGYN. What did you learn actually working in the world and working for this insurance company that was also VC-backed? What was broken in the system?
I'm not sure I actually learned more about what was broken in the system. Like, all of the empathy I built as the daughter of physicians. It wasn't that I went and worked in the business of healthcare and then realized everything was wrong. And I think that actually speaks to why everything's wrong. Like, when people are trying to do their jobs, I don't think it's, if I'm sitting at an insurance company, I'm not thinking about my impact on a patient's experience that day or a doctor's experience. Like, I'm just thinking about, frankly, my bottom line and how to run my business. It's not that I necessarily understood what was broken. I just learned how the system worked, which you have to. And that's, I think, you talked about, like, could you change the system while being a doctor? Well, one of the hardest things when you're a doctor is to learn the business of healthcare. Like, you're so busy practicing medicine. When do you have time or exposure to go figure out what every other party in the system is doing and how they're incentivized? That's what I got out of that experience.
So how did you get out of that rat race then? You weren't really fixing the system. You were looking at the bottom line. You said, hey, I've always wanted to be a leader. I wanted to go into the administrative side of healthcare. Stanford has amazing opportunities. They're on the cutting edge, especially when it comes to all of the tech, right? Silicon Valley. So you go over to Stanford, you get your MBA, and then what did you do?
Yeah, I mean, I had charted my path, right? Like, I knew that I was going to go learn the business of healthcare at an insurance company for a few years, but I ultimately had always intended to leave and move early stage and build something for providers. So I went to business school. I worked on various healthcare startup ideas, and then ultimately I left. And the first company I built was actually an insurance company, and I learned a lot from building that. We tried to make changes there, but ultimately my passion for healthcare has always come from wanting to do something for providers, who to me are like, they're just the key to having any healthcare at all. And that is what then made me leave that company and start Squad Health, because I spent almost like it was 6 years to get to where I am, but I knew I needed to get here.
And it's really interesting that the first startup actually that you went into after business school was doing what you did prior to business school, is to create a health insurance company. But then you go back to, the whole way to increase the bottom line, I would think, is to deny care, right? To cut the spending, to either negotiate rates that are low so that you can have a panel that is seeing patients at a reduced rate, or I guess you have to deny access. I don't know. How did that feel?
I guess I come back to what I said earlier. I'm not sure that's the level of empathy you're building while you're trying to work at an insurance company. Like I didn't think about it that way.
Yeah, but you still had to go back and see your parents at the dinner table. Did your parents look at you and say, Mallika, like, what are you doing? You're working for the devil. I don't know.
Yeah,
I think I would say that.
I mean, honestly, it's such a good question. You're making me think in a really interesting way about that experience. I actually think the truth is I built empathy for being an insurance company. And what I mean by that is you look at what it means to offer health insurance to members, and you absolutely have to find ways to control costs, right? So even when we're offering pharmacy plans, I was seeing what was happening to any one employer when two of their patients would go on some brand new therapy and it would just blow up their costs. And suddenly the premiums were astronomical the next year. Like that's what I was seeing, right? It's not like I was thinking, oh, we're trying to deny people care. I was thinking, well, we can't offer care if we can't figure out how to control costs across the entire population so this employer can afford it. And I actually think that it's not that I became cold-hearted. I actually think it just built like a real appreciation for all parties to some extent in the problems that they all have. And that has actually inspired a lot of what has, influenced the product I've built. Like, not to jump too far ahead, but even prior authorizations, they are not the devil. Like, I don't consider them the devil. I actually think they are necessary. Like at some point, you do need to be able to set rules about how and when you can pay for care. If there are no rules, like how could you possibly offer health insurance? I think the problem is the friction involved. Like if it was easy for everyone, I don't think doctors would complain. Like they would say, look, I take chart notes, and if those chart notes justify the diagnosis, that patient should obviously get the drug. That's, I think, what every doctor believes. I don't think a doctor, for the most part, is like, I should be able to write whatever I want in my chart note and the patient should be able to get whatever drug they want. Like that's just not the mentality. I think it's just very annoying to justify.
Yeah, but you know what?
Anyways,
you have medical necessity. I want to go back to what you said regarding prior authorizations, because I want to ask you if there's ever a need. So let's just say everybody is focused on the good and the betterment and following the rules, okay? Well, there are rules and guidelines for all medication. You have to have an indication for prescribing the medication. And so there is the indication, the patient fits the set of indications that are required. You know that this is the best medication for this patient. And I'm going to use an example. I'm going to say somebody like you, your age group, you're of childbearing years, you're a woman, and you have psoriatic arthritis. You don't, but I'm using that as an example. And Cimzia is the one drug that is safe to take for women of childbearing years. So knowing or thinking, okay, everybody's coming about it from the right perspective, doing what is best and looking at the indications, and then having to delay treatment or make it cost prohibitive that this patient, you cannot get this medication. That's really scary. Is there a need? Is there a need for prior authorizations? Is there ever a need?
It's such a good question. And Cimzia is a tricky one because I agree with you. I think when someone prescribes a drug like Cimzia, almost always they know why the doctor knows why they're prescribing it, and they have a very, very good reason for choosing that drug. There are other drugs where it's not as obvious. Like, I'll give you another input. Sometimes patients have preferences, right? Like they want a drug, and frankly, they will tell their doctor, prescribe me this drug or I'm leaving, like it's my way or the highway. They have strong preferences.
But they're not a doctor. But those patients are not doctors.
They're not the doctor. And it's not that necessarily the drug they want is harmful for them. It just literally may not be medically necessary, to your earlier point. And the doctor, I think, does what a doctor should do, which is to say, look, you are the member. It's your insurance company. If you liked this drug, it won't harm you. I'm happy to put forward the request. And that's all the doctor's doing. And it's very reasonable. But it's also very reasonable, I believe, for the insurance company to say it doesn't look like this is necessary. And according to our rules, we aren't going to pay for this. I think that's a reasonable response.
But isn't it the physician's responsibility to look at the indications for the drug and to choose the lowest level of drug? And I'm going to go back to rheumatology because I know this so well, but methotrexate, right? Usually that is the first choice if a patient needs to be, before a patient goes on a biologic, they're diagnosed with rheumatoid arthritis or psoriatic arthritis. I don't know. Maybe it's also for ankylosing spondylitis. I don't know. Now I'm like going far out of my reaches, but let's put them on methotrexate. Well, it's pennies to the dollar, right, for methotrexate. But there also are side effects. It's a very old drug. It's been around forever, but you can have hair loss. You can't give it to somebody who drinks alcohol. You can't give it to a female of childbearing years. So there are rules. But you know what? If you don't have those issues, this is what you need to go on. I don't want to call it step therapy. I want to say that is actually what doctors are taught. This is the protocol. You're not going to throw a patient on the most expensive drug that the patient is clamoring to take because their neighbor is on it, their friends are on it, they saw a great ad on TV. But it's the doctor's responsibility to say, you know what, this is the pathway that we need to go because of the disease you have. I'm just thinking in my head, if physicians had more power or took the power, and I say you can't be given the power, you can be given the authority, but you can take the power and say, I'm the doctor, you're seeing me because I'm the doctor, this is what my recommendation is. If that in a utopian society, right, worked and the patient was following those or the physician was following those protocols, would prior auths be needed?
In that case, I don't think so, right? Like I would say if that data existed and was available, and in theory, someone could audit it to make sure that what you're saying is true, I don't see you don't need prior auths, right? Because basically what you're saying is that we live in this world where people only prescribe according to clinical guidelines drugs like methotrexate, where there really aren't, it's not like 4 versions of methotrexate that are differently priced. And so, you're just trying to figure out which one to pay for. Like 100%, I don't see the value of a prior auth. I think the issue is that there's a world where you can't monitor that. Like, I don't even know if what you're saying is true. I mean, I believe what you're saying is true, frankly. I'm just trying to be empathetic to the other side, which is to say, if I can't validate what you're saying, and I need to have some sort of transparency, then maybe what I'm using is a prior auth. I guess, Meredith, let me actually tell you what I think should exist, because maybe
I'd love to hear.
This will also get to where you want to be. I actually, in some ways, don't think we should call these things prior auths anymore. Really, I think there should just be a real-time system where a doctor puts in a prescription, and it should just be very clear to that doctor whether the insurance company will pay for it or not pay for it based on the indications in the EMR. And that has nothing to do with, they should not be making clinical judgments and asking doctors to justify whether or not it's the right treatment. Like, in theory, an insurance company could just say, we don't cover drugs in rheumatology. I mean, they could say that, we don't cover drugs in rheumatology. And if that's your policy, then that's your policy, right? Like, if someone said that, and a doctor should just know that up front, they shouldn't have to justify their clinical decision-making to get that drug covered. It should be very clear whether or not you cover a drug. And if all of their clinical data, like those types of things, were readily available, you could easily automatically know those things. Do you know what I mean? Like, if that information was so clear and available, you would just know at the moment you're prescribing it whether or not it's covered and what the patient's going to end up paying. Because that's really what ends up mattering, is, can the patient even afford this drug?
But we don't know. And that's what makes it so difficult for coordination of care. Every insurance company is different. And then you have ERISA plans that are through the patient's employer, and they might be fully funded plans, and there are carve outs. And so You literally never know. It's the craziest thing. I mean, somebody might have an Aetna plan and they might have an Aetna PPO plan. But if this person has an Aetna PPO plan that's through their employer, they might have separate carve outs. Is there a way to get that information put into a database for extraction by medical practices?
There is, I think there is now. I don't think it exists in any current form, but we are building it because someone just needs to be responsible for getting this information in a database. But there is no one player. Like, who is responsible for that, right? Every payer has their own system. Every doctor has their own EMR. Like, who exists, whose job it is to monitor whether or not a patient can get covered for a drug, and then ultimately what it will cost them. There's nobody out there that does that today. That's literally what we want to be. We want to be the responsible party for figuring all of that out. But the hardest thing about doing it is obviously in healthcare, who pays for that? Like,
Right.
who is going to pay for this, right?
I would think that pharmaceutical companies would want to pay for it because getting patients on that drug is beneficial to that pharmaceutical company. And you and I started talking about this because I got really excited when I was at the Rheumatology Access Network conference, and I stood up and I said, there needs to be a platform that our care coordinators can go into and enter the patient's information, their insurance company, their diagnosis codes, anything that they failed prior to that, and submit it to actually get the formulary kicked back to them and the cost of the drug, right? And then also that platform can have the ability to go out and scope out patient assistance programs. It would help provide care much faster to patients, and the pharmaceutical companies would benefit ultimately. The insurance companies sure as hell wouldn't like it because now people are getting to treatment faster, because the truth is the turnaround time from staying on one insurance versus another, patients are leaving it in 2 or 3 years. So insurance companies are not looking at the long game. They're not looking at preventative care so that they don't have to pay for these super sick patients. Hopefully those who are prior to 65, once they're on 65, great. Maybe they're the government's, responsibility. And they are either way, because either it is traditional Medicare or they're on a Medicare Disadvantage plan, but it's being subsidized by the government, right? And so the profits continue to be raked in. But year after year, the patient can get kicked off of that MA plan that they are on, and then they have to go try to get onto another plan. So I just see this as a cycle of, instead of preventative care and let's get medication to patients where they're needed, we're looking at outliers in this situation, doctors who maybe are not doing the right thing. And I would say that those are far and few between, and there is not one source. So I want to go into what you're doing to solve these problems, because you and I could talk all day long about the problems. So you started a company providing insurance, and then what did you do after that? You're like, this isn't helping.
Yeah. I actually decided. So the insurance company I started, I frankly was sort of given a macro thesis, and I built a company off that macro thesis. And I took the exact opposite approach. When I decided to build providers, I decided I'm just going to spend a bunch of time with providers and let them tell me what they want help with. And so I just started consulting for lots of doctors, and I did everything, all independents. I did everything from website building and marketing to RCM, like everything. And the thing that I looked at every problem I could solve, and I'll try to go through the iteration quickly because I find it really interesting. But the number one problem that I think independent providers have is that they don't get paid as much as health systems or other healthcare parties for the same services they provide. And so I set out to solve that problem, wanting to build value-based care contracts for independent practices, especially specialty practices, who definitionally are more cost effective than any other option out there. And I was like, I should be able to help them accrue better economics, given that they are structurally cheaper and better for the system. And it was hard because payers are not incentivized to give any more money if they don't have to. They basically listen to the mafia, which are healthcare systems, but they don't really negotiate with the much smaller groups. And so I ultimately, during that phase, had built a navigation program, because to win in a value-based care contract, the key is keeping patients out of healthcare systems. You have to stay engaged with them. You have to manage them outside of your clinic so that they come to you when they have a problem and not go elsewhere, which is very expensive. Long story short, that navigation program, I turned into this pharmacy model, because one of the most burdensome issues for practices is helping patients navigate the process of being prescribed a drug to actually getting that drug and taking that drug. And once I started doing that, I realized how much of it could be automated, what a big problem it was across specialties, and then also that it was just ridiculous how much money practices were spending on this and almost never making money off of it, right? Like practices, and I'm sure yours does too, even if you do have an in-house dispensary, there are probably plenty of medications where your staff is triaging for hours, phone calls with the pharmacy, the patient, the payer, the manufacturer, triaging all sorts of issues to make sure the patient can actually get their meds, and probably not seeing a dime. And as much as you love the patient, you are also a business. Like, you have to pay your employees. You cannot do work for free. Nobody has ever done work for free. And to me, this was like the problem to solve. Like, not only was it one where you couldn't have really solved it before because it was not efficient to do this, right? Like, even your question around how could we know the coverage for every payer? How could we know the out-of-pocket costs for every drug? Like, that's expensive. You have to call payers, you have to run claims, you have to call the pharmacy. I mean, all of that stuff is expensive, and there's no business that could really support that work until you had the advent of AI. And now AI can automate a lot of those calls and kind of like database generation, et cetera. And you also actually have that alongside this huge demand, to your point around pharma. Like, there are so many new drugs in the market, and they are all having the same problem around access. So between being able to offer the types of services that you need to improve access efficiently, and then this huge outpouring of demand from new therapies and new drugs that are trying to get these medications into the hands of patients, it was just the perfect moment to build a business like this.
Well, what I love that you did is you went into consulting. And I don't know if I would call it as much consulting, but you were taking on various tasks for medical practices that they needed. You weren't necessarily saying, I know how to run your practice. You're saying, what are your biggest pain points and how can I help solve it? And I love that mentality. And it's so important, I think, in any business model that you're a part of, you really have to understand the inner workings to fix anything. And you thought at the very beginning, you would go into medicine. You learned that being a doctor may not create the biggest impact. You then went and traded money on Wall Street and then went into investment banking. You went back to grad school on the West Coast, and then you went to the insurance side because that's what you knew, and realized I wasn't creating a change. And I love that you were boots on the ground with doctors to try to see. I mean, yeah, you grew up in a family of doctors, but now you got to spread out even more and say, hey, what are the pain points now, right? Every year it's getting more and more difficult. So when did you launch Squad Health, and what is it doing to fix that pain point?
So we launched Squad about a year ago, and you described the status quo pretty well in the beginning of this episode, but maybe I'll start there and then talk about how Squad fixes the problem. So the experience today for most practices is that you send out a prescription to a pharmacy. You likely will get a fax back. Maybe you won't even get a fax back requesting a prior authorization. And then your staff will, pick up that fax, try to find the right prior authorization form, go into the clinical notes, try to recreate and understand why the doctor chose the prescription that they did by reading through pages of notes, labs, whatever, imaging, anything, to just re-justify all of that to the insurer. You may get a denial, in which case then the doctor has to get on the phone with someone at the insurance company to re-explain why they prescribed the medication. And then ultimately, if the drug is approved, you have to send it out to the right pharmacy. And you may have not even sent it to a pharmacy that can fill it because there's some network restriction or it's a limited distribution drug. And someone's got to get on the phone and talk to all these people, right? So all the work is annoying, and it's equally annoying when you spend like an hour waiting for someone to pick up your phone call just to talk to them. That's the experience today. And what naturally happens is, because you have so many cooks in the kitchen, you have the doctor, you have the patient, you have the payer, the pharmacy. It's like when no one's in charge of a problem, or when everyone's in charge of the problem, no one's in charge of the problem, balls get dropped and nobody knows whose fault it is, or everybody points fingers at everybody else. And I would say that's exactly what Squad fixes. So rather than that being the experience, if you send a prescription to Squad, we are a non-dispensing pharmacy that is basically a holding place for your script. So we don't dispense medication, but we hold that medication or that prescription while we triage all of those issues. We check what the patient's benefits are, if the drug is covered, what is the preferred pharmacy. We check if a prior auth is required. If one is required, we integrate with your EMR so we can automatically retrieve the clinical note and labs and anything else we need to complete the prior authorization form on your behalf. If there's a denial, we can automatically generate that letter of medical necessity so you don't have to get on the phone with insurance. We submit all of that, and then ultimately when it's approved, we route it to the appropriate pharmacy, and the whole time we're engaging the patient. So instead of the patient being in the dark and then potentially calling the practice a week or two later, angry about what is happening to their prescription, we are giving them updates. So if there are issues, if the payer is taking a long time to get back to us, we're notifying them. And so everyone is just so much happier. And most importantly, you only have to go to one person to figure out what's happening to that script, and it's us, and that's our platform.
Do you also go out into patient assistance programs or to look to see where the least expensive medication option would be for patients? How does it save them in their pocketbooks?
Yeah, you just described it. That's exactly what we do. So we identify pharmacies that would be the lowest out of pocket for the patient. And then we also will see and check if there are financial assistance programs, and then let the patients know about them so that we'll in fact actually help them enroll in those assistance programs to bring the out-of-pocket costs down.
So has this decreased the length of time it takes from the time a doctor prescribes a medication to the patient actually being able to take the medication versus another route, or the route that most practices are using right now?
Considerably. To give you a couple of stats, we can submit a prior authorization typically within 30 minutes of receiving a prescription. I mean, that's just unheard of in the industry today because we have so much automation. The other, anecdote that multiple practices have said to us, which I just love, is they're like, we can send a prescription out on Friday and it'll be approved by Monday. We never have staff working over the weekend, and you're like, yeah, well, that's the beauty of technology. You don't have to be in the office for us to do that work. So there's no delay.
So how many employees does Squad Health have?
We have our corporate team, which is comprised of engineers, operating folks, partner success for our provider groups. And then we have our healthcare team, we have a pharmacist on staff, we have pharmacy technicians, we have prior auth specialists who audit all of the AI responses. Right now, we're a team of 20, give or take, but we are growing fast. I think we've definitely hit a pain point that not only is just incredibly emotionally frustrating for practices, it's financially problematic. So we are growing very fast, and we're really excited about the effect we're having in the rheumatology space.
Who pays for Squad Health?
So we partner with pharma manufacturers who are very aligned with patients in getting access to these therapies. And we do not charge the practice. And that's really critical to our mission. Again, I started this company because I wanted to build something that helped independent practices survive and thrive. And so to me, it is mission critical that we are able to take off the burden of navigation for the pharmacy from the clinic to those that are well financed to support the workflows that I'm describing. So it's very much with pharma manufacturers.
What specialties are you focused on right now?
Yeah, so rheumatology is a big one for us. We're also pretty well spread out in GI, urology. We have oncology providers who are using our platform as well, allergy providers. Those are 4 or 5 of the main specialties that we have practices adopting our solution in.
So I want to wrap up this interview because I know you have an interview for kindergarten for your son, because that's what happens when you live in New York City. But if you could create one change, Mallika, within the American healthcare system, with all that you've seen, what is the one change that you would create?
I think for such a long time, technology has not been built for doctors. And I think that is one of the greatest reasons why there is burnout. And to your point, that burnout isn't just problematic because doctors get less hours of sleep. It literally affects their ability to advocate for themselves, to think about themselves as like business people that also need to have a reason to stay in medicine. And a large part of that is because the way that tools have been developed, they're usually sold into administrators, and you need all sorts of access and HIPAA regulation and privacy. And I think that the way that AI has completely changed our ability to integrate with systems, whether you see that through Scribes or even our platform, right? Like someone could get started on Squad's platform tomorrow. Because of how easily we integrate into existing systems. Like we are a tool for doctors. Like we're not there for the administrator. We're not there for some third party. Like we're there to make the doctor's life easier. And so I would say one of the greatest changes I hope that is in healthcare is doctors just don't spend time on stuff that is not care, that is not what they went into medicine to do. And I actually think AI will do that. I think it'll absolutely make the practice of medicine better.
And I will tell you, every doctor I know would agree with you. So thank you for sharing your insight.
Of course. Thanks so much for having me.
To everyone listening, the full video of this episode is now on YouTube. Search Working Healthcare and hit subscribe so you don't miss future interviews, short clips, and behind the scenes moments. Got a question, an episode idea, or someone you think I should feature? Drop me a line at meredithhirsh.com. And if this conversation hit home or made you think a little differently, don't keep it to yourself. Share the episode, tag a friend, or post about it on social media. You can follow Working Healthcare on Instagram, Facebook, and YouTube, and you can connect with me outside of those avenues on LinkedIn. That's where we keep the conversation going in between episodes. New episodes drop every Tuesday. Subscribe so you don't miss what's next, because you can't fix American healthcare unless you understand how it works. Tune in weekly as we explore the inner workings of healthcare.
You got me running,